This next session is titled Gastric Cancer as a Critical Healthcare Disparity. We have three wonderful speakers for this session, and then we'll plan on hopefully concluding this session close to 12:30, and then we'll do lunch. You'll have time to get lunch for about 30 minutes, and then we'll resume around 1 to 1:15. And continue having lunch while we've started our afternoon session. And also to let you know, at the end of the day, at the conclusion of this, we'll have a wine and cheese reception out here on the patio, and this will be a good time to network and to discuss various topics that you want to do. Okay, so without further ado, unfortunately, Meira, so our first speaker of this session is Meira Epplein. She's associate professor at Duke University, and she's a co-leader of the Cancer Risk Detection and Inception program. She was supposed to be here in person, but literally before she got on the plane, she got sick with upper respiratory symptoms, and so we all felt that it would be safest for her not to travel. So she was gracious enough to give a pre-recorded talk, and so we'll go ahead and listen to this, and then we'll move on with our two additional live speakers. So this is Meira's talk.
Hello, and I'm so sorry that I can't be there today, but thank you very much for still allowing me to present on a topic very important to me. Should we be screening for high-risk groups for Helicobacter pylori? So just to set the stage, let's talk about infection-associated cancers. So currently, we estimate about 15% of all cancers worldwide are caused by infection. So that's over 2 million cancers a year caused by infections. So what are those infections causing cancer? So we all know human papillomavirus, HPV, that we've developed a vaccine for to prevent against cervical cancer, potentially as well as head and neck and other oropharyngeal cancers. The hepatitis B and C viruses, for which we have a vaccine and treatment respectively for liver cancer, as well as other infections, including Epstein-Barr virus and liver flukes. But lo and behold, Helicobacter pylori is the leading cause of infection-associated cancers worldwide, accounting for 37% of infection-associated cancers. So that actually translates into 6% of cancers worldwide, as well as 89% of non-cardiac gastric cancers. Helicobacter pylori, what is it? I think this audience probably doesn't need to know, and you're going to hear, I think, a lot about this tomorrow with some real experts. But for a quick summary, for those who are not as familiar about this gram-negative spiral microaerophilic bacterium, it's currently assumed to infect about 50% of the world's population, so a very common bacteria. We think about 30% in the United States. And it's really interesting that it has infects such a large proportion of people, and we think it's been with us over time for hundreds of thousands of years. As human populations moved out of Africa, so did the bacteria. Really excitingly, there is effective antibiotic therapy. It's 2 weeks of 2 antibiotics plus a proton pump inhibitor, plus bismuth, probably. The issue is that there is increasing antibiotic resistance. A vaccine has not yet been successfully developed. There is one under development, and I think Phil Castle at the NCI is excited about talking about that more, and I look forward to hearing about that. Back in 1994, H. pylori was declared a class 1 human carcinogen due to its association with non-cardiac gastric cancer. And since then, there have been 7 randomized controlled trials, 6 in Asia and 1 in South America. And together, it shows that there's a 46% reduced risk of developing gastric cancer following eradication therapy. So almost cutting your risk in half by 2 weeks of treatment. Why aren't we treating everyone then? Well, there are some potential inverse associations that we've seen among people who've never had Helicobacter pylori appear to have a greater risk of developing gastroesophageal reflux disease and esophageal adenocarcinoma. I will note that in those randomized controlled trials that have followed individuals out for a number of years, they have not seen an increase in esophageal adenocarcinoma among the folks who were eradicated. So whether there is some protection from having H. pylori, but whether eradication of H. pylori older on at 40 or 45, which is what I would argue for as cancer screening guidelines like mammograms or colonoscopies, it's not that one is going to all of a sudden develop esophageal adenocarcinoma. There's also concern about recurrence, reinfection, and recrudescence. Absolutely. The most recent meta-analysis estimated these to be 4%, 3%, and 2% respectively annually. But there were real differences, and these rates were much higher in low socioeconomic status populations who also are more likely to harbor H. pylori and develop gastric cancer. So this is an important issue for us to work on. I will note, disparity-wise, something really important is that people of color are significantly more likely to harbor Helicobacter pylori, about a twofold increase in risk, if not more. And then what's interesting is that even among all H. pylori positive individuals, a recent study found that Black and Asian Americans compared to H. pylori positive white Americans were still 2 times more likely to develop stomach cancer. So there are cofactors and other things we need to be concerned about, but this disparity exists and is growing. Not a lot of studies have been done in the US, but I will say there was a couple of years ago a publication of the US veteran population where when they were able to document successful eradication versus persistent infection, the successful eradication was associated with a 76% reduction in risk. So definitely suggestions that this could be an important strategy in the US as well. So we're all familiar with the Correa cascade. I'm putting it up here just to show we know H. pylori infection. Chronic H. pylori infection generally happens when you're a child from your mother, your older siblings, or when you start school. And unfortunately, here in the US, we diagnose stomach cancer so late that we have a pretty low 5-year survival. What's really exciting is that H. pylori eradication has been shown to reduce risk for a wide piece in the middle, 15 to 20 years, all the way from non-atrophic gastritis to dysplasia and maybe even early gastric cancer. So why aren't we doing anything about this? One reason is that some people feel that H. pylori in the United States is disappearing. Well, our data from 4 large cancer epidemiology cohorts in the US, and these are years of birth on the x-axis cohorts and proportion H. pylori seropositive on the y-axis, you can see over time with newer cohorts, we do see a decline in H. pylori prevalence for our white population, but we don't see any suggestion of a decline in prevalence over time for our Black population in the US, which also means the disparity is growing. And just to hone in this point more, these are CAG antibodies. So we know CAG antibodies are a virulence factor that significantly even more increase your risk of gastric cancer. And again, we see a great disparity there and not a decrease over time. The other interesting thing we may have heard about are changes in trends of gastric cancer. And you can see down below here, while overall there's an annual decline in gastric cancer incidence in the US, among young folks, this under 50, and specifically among young white women, there appears to be a suggestion of an increasing trend. And a lot of questions have been what could be causing that. And some folks have suggested that it's not Helicobacter pylori because this population is the least likely to harbor H. pylori, although certainly some do. And these are really good questions. We were able to look at this question specifically in the Finnish maternity cohort, with 297 early onset gastric cancers, so gastric cancers occurring before age 50, and 210 traditional onset gastric cancer cases. And when we looked at blood samples taken at pregnancies, this is all white women from Finland, we actually saw that H. pylori was highly associated with gastric cancer, even in our early onset. In fact, there was no difference. We saw a 7-fold increase in risk for developing gastric cancer if we detected H. pylori antibodies. So you can see there, 68% of the cases in Finland were H. pylori positive at baseline compared to 23% of controls. We were also able to look at a marker for autoimmune gastritis in the blood, and we again saw a suggestion that autoimmune gastritis may also be increasing one's risk of gastric cancer, although certainly it's not suggested that it's stronger in our early onset population with an odds ratio of 3 compared to the pretty high odds ratio of our traditional onset. So again, another risk factor, but again, much less common in this population. So we detected these antibodies in about 11% in cases and 2% of controls. So again, H. pylori is still an important factor even for our young white women. So when is the time for translation? How do we target those at highest risk for eradication is really the big question to me. And we know it's been shown to be cost effective. So the American College of Gastroenterology guidelines are that anyone with a positive test of active infection should be treated. Fantastic. The question remains, who do we test? The recommendations from the ACG are specific to symptoms and diagnoses, including peptic ulcer disease, low-grade mild lymphoma, and early gastric cancer, as well as patients less than 6 years old with uninvestigated dyspepsia and no alarm features. There are some conditional recommendations related to medication use and a few other symptoms and diseases, but nothing related to high risk as we might think of it from a population standpoint. The Houston Consensus Conference followed a couple of years ago, led by David Graham, and they, after 2 days of multiple panels and meetings and inclusion of lots of different experts, agreed that everyone with a positive test of active infection should be treated, agreed with these, that anyone with ulcers and uninvestigated dyspepsia and mild lymphoma, but they added 3 other population level factors. People with a family history of gastric cancer, patients who are first-generation immigrants from high prevalence areas, and patients of Latino and African American racial or ethnic groups. And I would certainly add Asian American and American Indian Alaska Native to this group. So excitingly, using this kind of definition of high risk, not our symptoms or disease status, but rather population level risk factors such as first-degree family history, there was a randomized controlled trial in Korea. They had 1,676 individuals who had a first-degree family history of gastric cancer, randomized to clarithromycin triple therapy for 7 days, which is not even the standard anymore, but back then, or placebo. After a median follow-up of 9 years, there was twice as much gastric cancer in the placebo group as in the treatment group. Again, not large overall, 10 participants versus 23. But this still led to a very significant hazards ratio of, again, a 50% reduction in risk of developing gastric cancer with H. pylori treatment. I just really want to note here as well that of those 10 participants who were treated that went on to develop gastric cancer, 5 actually had persistent infection. Their overall eradication rate was 70%. It's not great, but it's what we see generally around the world. But just to note, if they had actually done the analysis of who was successfully treated, this would have been even higher. So this is just among those treated, not whether the treatment was successful. So what next? I think what we need to do is develop a precision prevention strategy for H. pylori test and treat among high-risk individuals, an algorithm. There are lots of actually other important topics, and I will leave them here, but come back to them at the end. This is definitely not it, but this is where I'm working right currently. So I'm really happy to introduce the Duke Cancer Health Disparities P20 of which I co-lead Project 2, called Racial Differences in Host Immune Response in Gastric Carcinogenesis, Translating Underlying Biology to Promote Gastric Cancer Interception. We also call ourselves GRACE. I just want to first just point out the GRACE team. They're amazing. I co-lead this project with Dr. Katie Garman, a gastroenterologist at Duke. We collaborate with Nina Salama, who a lot of you know, an H. pylori expert at the Fred Hutch. And we have just a really fantastic group of clinical research coordinators who recruit our participants, as well as increasing numbers of trainees. So we're very excited about that. So if we go back to that Correa cascade and we look at the Duke patient population, which is overall 19% African-American, which about reflects the catchment area of Duke Cancer Institute in Durham, North Carolina, we actually see how much our Black patients are overrepresented in all of the stages leading up to gastric cancer, including gastric cancer. So we see more African-American. We see 48% of our individuals with non-atrophic gastritis being African-American, 57% of our patients with intestinal metaplasia, and then 62% with gastric cancer. So our big questions for this grant are, how can we advance gastric cancer interception? And specifically, what are the benefits of H. pylori treatment and eradication? So this is a schema of our project. We are both developing a retrospective cohort and a prospective cohort and flipping the Correa cascade on vertically. And you can see we're looking specifically at individuals with Helicobacter pylori, but not in IM, individuals with intestinal metaplasia, and individuals with gastric cancer. I'm just going to give you a little bit of data from our retrospective cohort where we collected tissue. So these are all individuals seen in the Duke Endoscopy Clinic or for surgery where we have a tissue specimen available. And we also did a deep dive into their electronic health records. So we had 99 gastric cancer cases that we were able to obtain tissue samples on from 2015 to 2019. You can see more Black gastric cancer cases, 56, than our white, 43. And that overall, in the electronic health records, we saw that the majority had ever been tested for Helicobacter pylori. However, when we actually look at the timing of testing, we see a minority were tested prior to their cancer diagnosis, 30% of our Black gastric cancer patients and 23% of our white. And so we said, could this help? So if we know H. pylori test and treat helps reduce the incidence of gastric cancer, can it also help with gastric cancer survival and other gastric cancer outcomes? So this is exactly the question we asked. What is the association with survival by H. pylori testing prior to cancer diagnosis? So we were able to ascertain that 19 of our 99 gastric cancer retrospective cases had been tested for H. pylori and treated prior to cancer diagnosis. The hazards ratio for survival is 0.40, so a significant 60% reduction in risk of death from any cause for those individuals who prior to their gastric cancer had been tested and treated. So not only, as we've seen in those randomized clinical trials, does it reduce incidence, we have suggestions now that it improves survival. And we did have 8 individuals who tested negative for H. pylori prior to cancer diagnosis, and there's no association there. We excluded 1 patient who was tested for H. pylori, but we could not find evidence that they were treated. We did adjust for age, race, insurance status, treatment, and stage of diagnosis. Here's the full model for anyone who's excited to see. Again, we have that really strong decrease in risk of death for those who tested and were treated for H. pylori. We see that stage is a strong predictor of survival. And lo and behold, once we adjust for H. pylori test and treat, we don't see a significant increase in risk for mortality from our Black gastric cancer patients, even though nationwide, the greatest disparity in death rates from cancer is for gastric cancer, with Black men and women at over 2-fold increased risk of dying from gastric cancer compared to white men and women. We then limited our 99 cases to the 83 cases that have a North Carolina address for a number of reasons. One is we thought we might have better electronic health record data on those, and we don't want to bias against those that we don't have as good data. The other thing is we want to GIS map them. So we see about the same, a little bit over a 60% reduction in risk for those who were tested for H. pylori and treated prior to their cancer diagnosis, and about the same no association if you tested negative. What's really interesting is if we compare this model, and then we additionally adjust for neighborhood socioeconomic status. So this is Dr. Terry Hislop at Duke, who's now at Thomas Jefferson, developed neighborhood socioeconomic disadvantage. And what we saw is once we adjusted for that, we saw an even stronger hazards ratio for the protection that H. pylori test and treat provides for survival among people who develop gastric cancer. And I will note that the hazards ratio for African Americans goes down to 1.0. So once we adjust for these other social elements of health, as well as this potential interception of test and treat, we lose all racial disparity. So really exciting opportunity for interception. And I want to share with you one other project. We were fortunate to just be funded, our new project, Digest, Disparities in Gastric Cancer, expanding our understanding of the underlying reasons. So the P20 I just showed you was all local Duke data on Duke patients. This is a collaboration of large epidemiology cohorts. So we're collaborating with the Southern Community Cohort Study from Vanderbilt, the Multi-Ethnic Cohort Study from Hawaii, the Women's Health Initiative from the Fred Hutch, the PLCO trial that Hei-Jin Lin, who's here, is leading for us from Rutgers, and then the German Cancer Research Center. And what we're asking in Digest is, can we understand both the individual and neighborhood level factors that are associated with gastric cancer risk in a diverse population in the US? So the beauty of these 4 cohorts is that they are highly diverse, and so we are empowered to examine these associations among Black Americans, Asian Americans, Hispanic, Latino Americans, and white Americans. Aim 2 is to assess what drives the difference in race, in H. pylori antibody levels and atrophy, as measured by pepsinogen, and resulting gastric cancer risk. And then finally, to develop an integrated cells to society modeling framework to assess the impact of social determinants of health on these patterns of Helicobacter pylori antibody levels, gastric atrophy, and resulting gastric cancer risk. So just to give you a little bit of the preliminary data, obviously we just started, so we have no new data to show you, but the preliminary data is pretty exciting. So this is work we've done here in the Southeast with our Black and white patients for whom we had breath test and blood samples from. And we see that even among our H. pylori positive, VAC-A positive, CAG-A positive individuals, our African Americans have significantly higher antibodies to H. pylori than our white H. pylori positive individuals. And so the question is this another biomarker that we can use to help figure out who is at high risk and who can then we target for test and treat to prevent this deadly cancer? So then the question is, we haven't been using antibodies in a quantitative way for any sort of screening, but could this be relevant? And what we found with the breath test is that, lo and behold, when we set a cutoff for 91% specificity, both VAC-A and GROEL had very high sensitivity for current infection. It's a question we have with antibodies. Do they just show us ever H. pylori infection? They do, ever or current. But actually, by looking at the actual levels of the antibodies, we can really figure out who has current H. pylori infection, which is obviously really important if we then want to test and treat them. Well, the other question is, do these higher antibody levels actually correlate to increased gastric atrophy and increased gastric cancer risk? Well, the gastric cancer risk we're going to answer with this project, but the atrophy we do see. So this is actually work that I've done with colleagues in East Asia, where everyone had endoscopies and we also had blood. And we're able to show that for these exact same 4 H. pylori proteins, that increasing levels of antibodies are significantly associated with increasing gastric inflammation, suggesting this quantitative measure could be really really useful in helping us determine high-risk individuals. So what is next? As I mentioned, we are working on developing a precision prevention strategy for H. pylori test and treats. The answer to our question, should we be testing high-risk groups for H. pylori? Absolutely. We just have to really figure out who are the high-risk individuals, and that's what I think we're working on still. These other questions are equally important if we're going to actually be able to implement this. We need to address the issue of increasing H. pylori antibiotic resistance. We need to improve patient adherence to treatment. This is work that I've done in the community, realizing that it is still a lot of work to take 2 weeks of antibiotics, and something that we need to talk to our patients about. We need to determine other major factors for treatment efficacy. If we're around a 70% eradication rate, we need to better understand why we aren't hitting better numbers. We need to improve physician adherence to guidelines, particularly retesting. At Duke, we are about 40% of H. pylori positive treated individuals are retested. That's much too low. That's what we see nationwide, if not lower. It's part of the guidelines. You have to be retested. A persistent infection is something we need to take care of. And finally, we need to change policy. Insurance guidelines right now do not allow for testing of individuals that don't fit into one of the guidelines. But I would suggest once we determine these other high-risk factors, say first-degree family history, say high levels of antibodies, we need to have insurance actually pay for the testing. So with that, I will say thank you very much to all of my colleagues, to everyone there that I'm not getting to see. I'm really sorry, and I miss seeing you all. And I really have to just give a special shout out to Julia Butch at the German Cancer Research Center, who has done so much of this biomarker work. Thank you.